Hello, my dear doctors. So, we're going to continue with our presentations for the Mrcp cases. I'm going to talk a bit about the respiratory station today, and we'll be talking about the pulmonary fibrosis. Now, this is a very, very common case in respiratory station, and you must know everything about the pulmonary fibrosis in order to get through this station. So, how you will present the case? Obviously, going to do the examination first, and I'm going to give you some tips where you can find the diagnosis even without doing the chest examination. The general examination also um, you may know about the diagnosis. Anyhow, so the presentations, first of all, we're going to in your presentation we're going to talk about the positive clinical findings and diagnosis. Then we're going to talk about the complications, differential diagnosis, and workup. So this one should be your pattern for the presentations. Okay, so general examination. Obviously, going to once you're examining the patient, you just see whether the patient is breathless or not. It's a good idea to count the respiratory rate, look for any oxygen supplementations, look for any cyanosis or clubbing, or maybe signs of uh, any connective tissue disease like SLE rash, or maybe having any signs of rheumatoid arthritis like rheumatoid hands. General examination is very important because if you are in a respiratory station and you already see the patient has clubbing, then immediately you should think about the possible causes of the clubbing. One of the causes is pulmonary fibrosis. There are other causes of the clubbing as well. Going to talk about it a bit later. So very important that take a good look at the patient, look at the general appearance, look for any oxygen supplementation, count the respiratory rate. Okay, so once you have completed your general examination, you may be having some idea that what could be the cause in this patient. And then we move on and do the chest examination. Obviously going to start with the inspection and look for any scars, maybe from the previous wart surgery or maybe because of the biopsy. We look at the expansion of the lungs. Expansion may be reduced if there is a advanced pulmonary fibrosis. Percussion note, we expect the percussion note to be resonant. And on auscultation, you may find bilateral fine and inspiratory crackles. It can be at the base, it can be at the apical, and there are differential diagnoses for the cracks at the base or the apical. So once you have done your chest examination and you have some idea that the patient is likely to have a pulmonary fibrosis, then the next step is you want to look for any complications of the pulmonary fibrosis. Keep all these things in mind because once you're doing the presentation, you have to follow this sequence. So in complications, there are a few complications which are very important, like carpulmonale. In this, the patient may have increased JVP and peripheral edema. If the patient has another complication is pulmonary hypertension, in which you may find JVP with giant V waves. You may have right ventricular heave or peripheral edema as well. And then once you find the CREPS, you should think about the differential diagnosis, maybe left ventricular failure, or it can be because of the bronchiectasis as well. These are always, we get confused with the CREPS, whether these CREPS are because of bronchiectasis or pulmonary fibrosis. But remember, in bronchiectasis, they got coarse CREPS, and you may have some V's or squeaks there. Another important thing is once you put the stethoscope and you find the CREPS, you ask the patient to cough and again listen at the same area, and sometimes there may be change of the character of the CREPS, or the CREPS may disappear. So this finding is more likely towards the bronchiectasis. Talking briefly about the causes of the idiopathic pulmonary fibrosis. So there On the top of the list, I put idiopathic pulmonary fibrosis because this is the most common cause of the pulmonary fibrosis. It can happen, pulmonary fibrosis can happen because of the vasculitides like Sjögren's and Wegener's granulomatosis. Connective tissue disease and rheumatological diseases. It can be because of the eosinophilic pneumonias, drugs and radiations, sarcoidosis or tuberculosis. So these are some important causes of the pulmonary fibrosis. And suppose if you came across apical fibrosis, so remember that the apical fibrosis, remember this mnemonic stars. So S stands for sarcoidosis, T for tuberculosis, ankylosing spondylitis, radiation, and several inhaled agents like extrinsic allergic alveolitis and silicosis. So remember this stars, and then this is the DD for the apical fibrosis. If you find the clefts on the apices, then you can put this differential diagnosis. So let's talk a bit about the workup, how you will work up the patient with pulmonary fibrosis. Obviously, first of all, we want to look at the history. In the history, it is important to look for any features of connective tissue disease. We want to ask about the occupation and any environmental exposure. We want to ask about the medications, very important because there are many medications which can cause pulmonary fibrosis. And we will also ask about the family history. After the history, we want to do some blood tests. So like to do the autoimmune screen. We want to do ANA, ENA, ANCA, rheumatoid factor and CK. Pulmonary function tests will be the next. The pulmonary function test, we want to look at the spirometry, expecting the restrictive pattern there, lung volumes and gas transfer. Chest X-ray will do high-resolution CT scan, which will confirm the diagnosis of the pulmonary fibrosis and gives us some idea about whether we have a ground glass appearance or honeycombing, and it will give us some idea about the cause of the pulmonary fibrosis. And finally, we have to refer the patient to the interstitial lung disease multidisciplinary team. Okay, so this was all about the workup for the patient, and then this is the most important part, that how you will present the case. So presentation, as I've already told you, that just follow this sequence, this one which I mentioned before, that positive clinical findings first and diagnosis, then we go to complication, DD and workup. So in the presentation, we'll start by, if you know the name of the patient is okay. If you don't know the name, still is fine. You can say this 70-year-old gentleman presenting with SOB. On examination, he's short of breath with respiratory rate. You count to the respiratory rate, just tell them. Then we start with the general examination. So the patient has a finger clubbing. And if there's any other positive finding on the general examination, just mention it. And then you move on to chest examination. On auscultation, patient has bibasal, fine and inspiratory crackles. Okay. So this, after the chest examination, then you will move on to talk about the important negative findings. There is no evidence of called pulmonale or connective tissue disease. So my findings are consistent with idiopathic pulmonary fibrosis. So suppose if you don't have any clue about the cause of the pulmonary fibrosis, you can safely put idiopathic pulmonary fibrosis by mentioning that you don't find any evidence of called pulmonale or connective tissue disease. Then you will not stop there, you will continue and you say mild differential diagnosis include other causes of pulmonary fibrosis, which I'm going to explore by taking a full history, particularly focusing on connective tissue disease, occupational, environmental exposure, family history, and drug history. I would like to conclude my examination by taking full set observation, arrange pulmonary function test and chest X-ray. And if I find that restrictive pattern in the pulmonary function test and some chest X-ray findings, I like to do the HRCT thorax, which will give us more idea about the pulmonary fibrosis. And finally, I like to discuss with interstitial lung disease multidisciplinary team. So this is how your presentation should be in case of a pulmonary fibrosis. And if you follow my pattern, you're not going to miss anything actually. I mentioned some common questions which they usually ask in this respiratory session if you come across pulmonary fibrosis. So first of all, they may ask how you investigate the patients. So here you have to, again, as I told you in my previous presentation, just divide into groups. So first of all, we're going to talk about the blood tests. You want to do full blood count. You want to do the urea and electrolytes, autoimmune screen. If you're suspecting specific allergic alveolitis, we want to do the specific precipitants. If you're thinking about sarcoidosis, we want to do the ACE level as well. However, ACE level, this is not diagnostic for the sarcoidosis. Pulmonary function tests, and we expect to see the restrictive pattern. We want to do the chest X-ray. If particularly you're talking about the idiopathic pulmonary fibrosis, then there will be peripheral reticular shadowing, mostly in the low zone, and high resolution CT scan also will have peripheral, basal, and sub-pleural reticulations. There may be some honeycombing, but usually no ground glass changes. And finally, invasive investigations like bronchoscopy for biopsy and lavage. Lavage is not much helpful, but can be helpful if you suspect in sarcoidosis. And Watt's lung biopsy. So just divide the investigations and into groups so you don't miss anything. Another question which they may ask is about the management of idiopathic pulmonary fibrosis, again divided into different groups. So management can be supportive, like breathlessness management technique and oxygen inhalation. There are some drugs available if you're talking about idiopathic pulmonary fibrosis. One of it is pirfenidone, which is antifibrotic, and it is recommended if the patient has FVC between 50 to 80%. Another drug is tyrosine kinase inhibitor, and it's called nintedanib, and this is, however, not available in the UK. It's only used in USA. Patient may have some GERD symptoms. That is also part of supportive treatment. You have to treat that one. Patient needs pulmonary rehabilitation, and sometimes the patient may need lung transplant, especially if it is younger patient. Okay, so just divide in the groups and tell about the management and follow the sequence. They may ask you about what are the drugs which normally causes pulmonary fibrosis. So it's worth memorizing few drugs which can cause pulmonary fibrosis, and include methotrexate, amiodarone, cyclophosphamide and bleomycin, nitrofurantoin, and sulfasalazine. So remember these drugs which can cause pulmonary fibrosis. Then they may ask you about other causes of the clubbing. So remember the other causes of clubbing. It can happen, clubbing you can see in lung cancer, cystic fibrosis, non-cystic fibrosis, bronchiectasis, and then other conditions which are related to lung include empyema, lung abscess, or tuberculosis. So that's it for the pulmonary fibrosis. Just be confident, and no need to study a lot in PACES examination. Just be focused and be prepared for the questions. They are normally, the questions are quite predictable, so no need to worry about it. Okay, thank you very much, and I'll talk to you again about other cases in my next video.